Welcome everyone to the first ever TIMI Talks podcast. I'm Nick Marston here with my good friend and colleague, David Berg. David and I are cardiologists and investigators here at the TIMI Study Group in Boston. And we're going to be moderating this new podcast in which we intend to pull back the curtain on the TIMI Study Group experience for anyone who is interested in joining us. David, welcome to the podcast. Are you ready to get things kicked off?
Thanks, Nick. I definitely am. Some of the things that drew me to the field of cardiovascular medicine back when I was a medical student were the strong traditions of discovery and innovation, and really the commitment of the cardiovascular community as a whole to building the evidence base that supports the clinical decisions we make all the time. That's really at the heart of what TIMI does. And so the motivation for this podcast was really to create a space to talk about clinical trials and the latest developments in cardiovascular medicine.
And we really want to make this podcast conversational, hopefully reproducing the kind of discussions about clinical trials and cardiology headlines that routinely occur around the office. Unfortunately for the listeners, it won't just be the two of us that you'll be hearing from. Every episode, we'll be bringing on colleagues with specific expertise on the topic of interest to hear their opinions and their views on the hottest areas in cardiology.
Yeah, and I'll add that we also hope to bring on many of the incredibly talented and inspiring members of the broader cardiovascular community outside the walls of TIMI onto the podcast.
Great. So David, now that we've introduced the podcast, I feel like we should also give a bit of background on the TIMI Study Group for those who might not be entirely familiar with it. I'm sure some listeners are aware of the clinical trials that TIMI has led over the decades, and some may have experience with the clinical risk tools that have been developed at TIMI, including the TIMI risk score for unstable angina and NSTEMI, and TIMI flow grade for assessing coronary lesions. But perhaps you could provide some background on what exactly the TIMI Study Group is and maybe a glimpse into its nearly 40-year history.
Definitely. So TIMI is an academic research organization, or an ARO, affiliated with the Brigham and Women's Hospital and Harvard Medical School. It was established in 1984 by the NHLBI to test emerging cardiovascular therapies in multi-center clinical trials. Before that was the mainstay of cardiovascular medicine. At the time, Dr. Eugene Braunwald was the chair of medicine at the Brigham, and he was asked to chair the TIMI Study Group. The first TIMI trial was a study of lytics. It was a comparison of IV TPA versus streptokinase in patients with STEMI. But over time, the scope of TIMI trials has really expanded beyond acute coronary syndromes and now includes patients with stable atherosclerotic cardiovascular disease, patients with cardiometabolic risk factors like diabetes and obesity, patients with arrhythmias like atrial fibrillation, and patients with heart failure. Our trials span from smaller phase 2 trials all the way up to phase 3 and phase 4 cardiovascular outcomes trials. At TIMI, we're a big team. So there are 12 PIs. We have fellows who come from all over the world to train in the design and execution of clinical trials. We have a large team of biostatisticians and more than 100 other employees who help support trial operations.
Well, very well said, David. And, we'll definitely, just a reminder, we'll definitely have to get Dr. Braunwald on the podcast early to hear more about the early days of TIMI. It's always fun to hear. As for me, I remember when I first became aware of the TIMI Study Group as a medical student, I was doing a summer research project on postoperative troponins between first and second year. And I kept coming across all these papers by a group of authors from the Brigham, Dr. Morrow, Dr. Sabatine, Dr. Braunwald, and many others. And my research mentor at the time, Ed McFalls at the Minneapolis VA, he gave me a copy, my first ever copy of Braunwald's heart disease. I really had no business reading it as a second-year medical student, but it certainly put the TIMI Study Group on the map for me at a very early stage in my career. I'm curious when you first became aware of TIMI and how you got involved, because I know you got involved very early.
Yeah, that's a great story. I love the image of you being betrothed your first volume of Braunwald's heart disease. Yeah. So for me, I did, when I was a fourth year medical student, I did a cardiology rotation at the Brigham. And I rotated with Dr. Joe Liscalzo, who at the time was the chair of medicine here. And at the end of my rotation, I told him I was interested in learning more about clinical trials. And he actually connected me with Dr. Mark Sabatine, who was the newly minted chair of the TIMI Study Group at the time. Mark then connected me with Dr. Jessica Mega, who was leading a trial called Elevate TIMI 56, which was a study looking at optimal clopidogrel dosing in relation to CYP2C19 genotype. And Jess and Mark really invited me to join the trial team and learn more about the ins and outs of clinical trials. And I have to admit, I was totally starstruck. And that's really when I caught the clinical research bug and first thought about coming back to TIMI for research fellowship after completing my clinical training.
That's great to have been involved so early on in TIMI. I remember when I was a resident, the TIMI Study Group just kept coming up. I was at UC San Diego, over 3,000 miles away from Boston, but I very quickly learned as an intern that Dr. Braunwald was the founding chairman of medicine at UC San Diego. And although it had been 40 years since he left for the Brigham, his name just kept coming up, and he had a very long-lasting impact on that program. Then, of course, during residency, there were some big trials that came out from the TIMI Study Group while I was a senior resident, like Improve It and Pegasus. Both of those were published in the New England Journal of Medicine and changed practice. And so that, along with continued biomarker papers that were coming out of the TIMI group, it gradually became more clear to me that I was ready to leave the perfect weather of sunny San Diego for the Brigham and the opportunity to do clinical trial training as a TIMI fellow. So that's what brought me across the country here, and it's where I ended up meeting you.
Yep. And then, of course, we went through TIMI fellowship together, right? And we're classmates at the Harvard School of Public Health. And ultimately, we joined the faculty here at the Brigham at the same time. And now, of course, we have offices right next to each other with relatively thin walls, I might add, so I can spy on you at any time. But it's only fitting, I guess, that we then join forces to launch this podcast together.
For sure. And despite all the similarities in our career path over these last 7 or 8 years, we've found ourselves at somewhat the opposite ends of the spectrum in terms of our clinical interests, expertise, and research focus. So I'm a preventive cardiologist in our cardiovascular genetics and preventive cardiology sections here at the Brigham. And I'm involved in clinical trials testing novel lipid-lowering therapies for genetically validated targets such as PCSK9, ANGPTL3, and ApoC3. I also help lead our TIMI genetics team along with Christian Ruff, where we focus on the translation of genomic science into clinical practice. And I still do some biomarker work as well with David Morrow, and that may be our one remaining area of overlap, David.
Yeah, no, I think all awesome stuff that you have been up to since you've been at TIMI. Like you said, I sort of am on the other end of the cardiovascular spectrum. So I trained in both cardiovascular medicine and critical care medicine, and now largely practice as a critical care cardiologist in our cardiac intensive care unit here at the Brigham. My research interests are really in acute cardiovascular care, particularly in cardiogenic shock. And I'm also interested in the care of patients with heart failure, which is a large proportion of the population of patients that I care for in the cardiac ICU. And so the clinical trials and research studies that I'm involved in are really focused on patients either with cardiac critical illness or with heart failure. And like you said, I have a particular interest in using protein biomarkers to help refine risk prediction, understand mechanisms of disease, and ultimately personalized treatment approaches.
Yeah, it's really incredible work that you've been involved with and has been so cool to see. And I think given that we do have these different perspectives, I think it'll be a nice we'll complement each other nicely on this podcast. So now that we've successfully introed the podcast and shared a bit about TIMI and our backgrounds, I think we should shift gears to a little ACC preview.
That sounds great.
All right, so the American College of Cardiology and World of Cardiology Congress meeting will be held in New Orleans this weekend. It's going to be a lot of great science, the clinical trials. We're really excited for it. And for those of us who are in cold climates, it's going to be a nice escape from the winter weather. I know yesterday we had a snow day here in Boston, so I'm looking forward to that.
Yeah, totally. I remember going to my first ACC, which was in 2015, just before I started cardiology fellowship. It was in San Diego, as I'm sure you remember. And I remember walking away from that conference with two primary thoughts. First, why don't I live in San Diego? And second, what a totally awesome field to be joining. It really did sort of whet my appetite and get me excited for beginning cardiology fellowship. There's a lot of great things happening, like you said. I'm curious, what are you most looking forward to at this year's ACC?
Yeah, there is a lot to be excited about. I mean, I think before I get into the science, I have to say I'm looking forward to seeing a lot of friends and colleagues in person. Sometimes it takes these meetings just to get dinner with friends from your own institution, as we will be doing this weekend. So I'm looking forward to that. Additionally, seeing people that you work with and you're on calls with every week in meetings, like trial sponsors, will be nice. During COVID, we did the entire Translate trial without ever meeting the sponsor in person. And so I'm looking forward to meeting those that I'm working with every week. And I think just really have a new appreciation for the opportunity to get everyone together and work in person. As for the science, I think there's a lot of exciting presentations. I guess I'll open from a preventive cardiology perspective. We've got a phase 2 trial of Merck's oral PCSK9 inhibitor being presented by Christy Ballantine. That's going to be a late breaking presentation on Monday. I always check the Monday schedule to see when I should book my flight out. And this one definitely made me book a later flight on Monday. So I'll make sure to catch that. There's also a PCSK9 inhibitor coronary CT trial called Yellow 3. That'll be on Saturday. Should be good. And then, of course, the CLEAR Outcomes trial, the cardiovascular outcomes trial, which, again, I may be biased, but I think this is clearly the headlining trial at ACC. It's got the primetime spot Saturday morning at 9:30, just after the opening showcase. And Steve Nichols will be presenting this with Dr. Fuster chairing and our own Michelle O'Donoghue as a panel discussant. So not sure what more you'd want. I'll make sure to save you a seat, David, just like I did at AHA last year.
Thank you. I appreciate that. And I'll be rolling in 2 minutes before it starts. So keep that seat warm. Yeah. So tell me, acknowledging your bias, tell me what it is about CLEAR Outcomes that has you so excited. What's CLEAR Outcomes all about?
Yeah. I mean, I think that, first of all, this is a cardiovascular outcomes trial, which always gets a trialist excited, but it's the first cardiovascular outcomes trial for bempedoic acid, right? Which is, of course, an LDL lowering therapy that's been approved now for 2 years, approved by the FDA and available to use in the US. I've used it in clinic for certain patients, but it is just one of now a handful of therapies that are approved for LDL lowering. And it's still overshadowed, of course, by statins, PCSK9 inhibitor monoclonal antibodies, and ezetimibe, all of which have outcomes data further supporting their use. So I think with CLEAR Outcomes, it's really an opportunity for bempedoic acid to have more data to support its use clinically. Here, for CLEAR Outcomes to kind of find this answer, it's studying the drug in over 14,000 patients, so a very large trial, and these are all patients with ASCVD and LDL over 100 milligrams per deciliter. So a very typical outcomes trial population for lipid-lowering trial. But what's unique about this trial design, it's only including patients with statin intolerance. So clinically, this could be as many as 15 to 20% of patients who try statins that end up complaining of some sort of muscle symptoms like myalgias. So there's definitely a need here, but I think it's notable that the study team, went after this more narrow population rather than the broader population, which I think makes sense. Instead of competing with other therapies, there's an opportunity here for bempedoic acid to really rise to the top of choices for patients with statin intolerance and maybe even be a first-line agent if the data looks good. We already know the top-line results are positive from this trial. So the question really is now how significant and which specific endpoints are significant. So we'll have to wait and see. But I think from prior lipid trial data, we can make a pretty good guess of what the lipid lowering effect may be on cardiovascular outcomes. The Cholesterol Treatment Trialist Collaboration, CTTC, has done a lot of work looking at meta-analyses of lipid lowering trials. And so from there, we know that there's an approximately 20% relative risk reduction for every 39 milligrams per deciliter you lower LDL. So if we kind of do the back of the envelope calculator here, in CLEAR Outcomes, we know from the design paper that the baseline LDL in this trial is 139 milligrams per deciliter, so pretty high, juicy LDL cholesterol to start. And then we know from CLEAR Serenity, one of the phase 3 lipid lowering trials, that this drug lowers LDL by about 21% in a statin intolerant population. So 21% reduction from that starting LDL gives us about a 29 or 30 point reduction. And this LDL reduction should then translate to an approximately 15% relative risk reduction, or a hazard ratio of 0.85. So that's kind of the ballpark of where I'm anticipating the treatment effect being for cardiovascular events, is a 15% relative risk reduction. David, what do you think? Are you going to take the over or under on that?
I guess, I love the rigor that you just went through to arrive at 15%. But I'm going to go with over. I'm always the optimist. So maybe we'll see even a little juicier than 15%.
That would be great. Then we may get the audible gasp from the audience, which is always fun at the late breaking sessions. And then, of course, always important in these large trials with, a lot of patients and long follow-up to focus in on safety and tolerability. We have seen some signals in earlier trials for an increased risk of gout. So be looking for that, as well as looking for a signal for cardiovascular death, which both of those, of course, will have a big impact on what the uptake will be ultimately for bempedoic acid. David, what about you? Any late breakers that catch your attention?
Yeah, I think that there's a lot of great late breakers on the docket. I think one that is going to be a big headliner is the Triluminate pivotal trial. All eyes will really be on the tricuspid valve at ACC, and that's actually being presented in the same session as Clear Outcomes. So the conference will be starting off with a bang. Triluminate Pivotal is a randomized trial of tricuspid transcatheter edge-to-edge repair as compared with medical therapy in about 450 patients with symptomatic severe tricuspid regurgitation who aren't candidates for tricuspid valve surgery. And the primary endpoint in that study is a hierarchical composite of time to all-cause death or tricuspid valve surgery, total number of heart failure hospitalizations, or improvement in heart failure-related health status as measured by change in Kansas City Cardiomyopathy Questionnaire symptoms. We actually don't know which component of the KCCQ, but looking at change in that health status over the course of 12 months. And we got a sneak preview about the efficacy and safety of the TriClip at ESC and TCT last fall, where preliminary results of patients enrolled in the so-called roll-in cohort were presented. So the study design allowed centers who had limited experience with this technology to enroll up to 3 patients directly into the TriClip arm before starting to randomize. And so from those data, we, at least from a procedural success standpoint, we already have a sense that the data look very encouraging, but this is really the first time that we're going to see results that are going to be controlled, that are compared to a control group. And so I think there's a couple key questions as we see the data presented, and one of which is that among those patients that enrolled in the trial, what's the nature of their tricuspid valve disease? We certainly know that the bulk of tricuspid regurgitation is secondary or functional, and there's some exclusions in this trial related to tricuspid valve leaflet anatomy. So I suspect that will further select for a secondary TR population, but I think if we learned anything from the trials of the mitral transcatheter edge-to-edge repair techniques, it's that there may be important differences between study populations with respect to valve characteristics that are really important to understand when interpreting the clinical trial results. So I'll be paying attention to that for sure. The other thing is I'll be interested to see which components, if any, are most impacted by the intervention. The trial obviously is, given its size, it may not be adequately powered for some of the harder endpoints of the composite outcome, but what you'd love to see is some directional consistency in the effects of the intervention across each of the components. And then, of course, we won't have a good sense of the durability of this intervention at this point, given the follow-up, but we'll no doubt be learning a lot more about that in the years ahead.
Well, thanks, David. Those will no doubt be some exciting studies and really an action-packed first session that Saturday morning. And of course, there'll be a lot of other great science at ACC throughout the 3-day weekend that we're really looking forward to. Well, that seems like a pretty good place to wrap things up for today, but we'll certainly be catching up with you all again after the conference.
Yes, and of course, we definitely look forward to seeing many of you there. So hopefully we'll catch you in New Orleans. Before we go, I do want to thank our producer, Kate Brennan at the TIMI Study Group, for all of the behind-the-scenes work done to make this podcast a reality on very short notice. So thank you, Kate, for all that you've done and all that you'll continue to do for this podcast. So for the TIMI Talks podcast, this is David and Nick signing off.
Thank you for listening. Join us on the next episode where we'll be recapping the ACC scientific sessions.